we're going to be obviously discussing the APPG on smoking and health's report, which we're launching together with recommendations for the forthcoming control plan for England. So in terms of the housekeeping, can I just make sure everyone who's not speaking, please keep yourself muted. You'll need to do that to make sure you're not muted, so we don't get any extraneous noise. But Ash staff will mute anyone who's not speaking and is not muted. So we will control that if you don't do it yourself. The meeting is going to be recorded, and a recording of the presentations will be available after the event and loaded onto the website of the APPG on the Ash website. So if anyone has questions for any of the panelists, can you type any questions for the Q&A, which is going to come towards the end of the session at the chat function on the right hand side of your screen. And obviously keep yourself on mute and put any follow-ups in that chat function also. We've only got a very limited time for question and answers, so I'm almost certainly we won't be able to take everyone that wants to ask a question. But I think that's all fairly clear. I think most people now will be used to Teams or Zoom, WebEx, or all sorts of other video technology. So I think we're all pretty clear on how to do that. But I'm sure that people will still, unfortunately, transgress the rules. Now I think Jo is with. Yes, there. Yeah, she comes up as Jo. You come up as J Meetings, just to confuse us overall. But
apologies. I'll rename my handle, whatever it's called. I desperately yearn for the time when we're not doing it like this, and we have a human contact. I've had a couple of very sparse meetings now, and I get slightly overexcited, like somebody who's been invited to a party, and there's perhaps only 2 people in the room with me. But anyway, good morning, everyone.
Good morning, Jo. Anyway, but as we're slightly informal in this process because we know each other quite well. But let's be quite clear. We're all, I think, delighted to be joined together by the Public Health Minister, Jo Churchill, who is going to be our keynote speaker and will speak to us in a few minutes. And indeed, it's fair to say it's thanks to her that we're actually here today, because following her announcement just before Christmas, which I think for all of us was a very welcome early Christmas present, that there would be a new tobacco control plan for this year. We look forward, obviously, to her hearing about that and the timeframes for it to be released. The APPG for Action on Smoking and Health has a very honourable track record in producing recommendations for the government on tobacco control, long before I became the chairman. And I'm sure that it will continue long after I've ceased to be the chairman. But so after the minister's announcement, and with the support and help from Ash, which provides the secretariat for our APPG and the wide spectrum academic research consortium, we've pulled together what we believe to be a very comprehensive set of recommendations, which will achieve what we all want to see, which is a smoke-free 2030. Obviously, we've got a distinguished panel of guests to speak to you, and they'll go through the detailed recommendations. But I just want to point to the level of support that the recommendations have received. They've been endorsed by leading health organisations like the Academy for the Medical Royal Colleges, the Association of Directors of Public Health, the British Heart Foundation, Cancer Research UK, the Faculty of Public Health and the Health Foundation, amongst numerous others, and no doubt there'll be lots of social media activity today as this report is read and put out into the public domain. Our recommendations are not just supported by the experts, but also by the public who support the government's ambition, and also the public measures that are required to deliver it. The need for government intervention is supported by voters of all parties. For example, more than 3/4 of those surveyed who voted Conservative, Labour or Liberal Democrat in the 2019 general election support the idea of a levy on tobacco manufacturers. I hope the Minister will be interested to note that the strongest support for raising the age of sale to 21 comes from those who voted Conservative in 2019, 2/3 of whom support raising the age of sale to 21, compared to a miserly 63% of Labour voters and 64% of Liberal Democrat voters. We recognise, obviously, that putting together a comprehensive tobacco control plan takes time, and our report models the impact of the proposals, assuming that they're put in place by the end of this year. So that gives you, Joe, some wriggle room as ever. So we're looking forward to, obviously, to hearing from the Minister, and I'm very pleased to introduce Joe Churchill, the Minister for Prevention, Public Health and Primary Care, who will deliver our keynote speech. Over to you, Joe.
Thank you very much indeed. And with or without the extra polling, I think the appetite for lifting the age of being able to purchase cigarettes is quite interesting. But thank you for inviting me to speak at today's launch of the new tobacco control plan. I listened to Mary actually on Radio 4 this morning talking about the recommendations, and I'd like to thank all of you for, well, basically keeping the pressure up and your tireless work on tobacco control, and for the interesting recommendations in the new report, many of which reflect those same priorities that we're looking at for the new strategy. Since the publication of the Tobacco Control Plan in 2017, we know that smoking prevalence has fallen to an all-time low of 13.9%. And there is some success in that public health story. However, behind a blanket figure, as we all know, can often lie a great deal of other information, and smoking's still responsible for somewhere around 75,000 deaths a year. It masks that reduction, that although that sounds good at a national level, we have significant health inequalities, and we know that you can be born and raised in parts of the country where smoking is very, very low, but in other parts of the country it's still 1 in 4. And actually it's that variation that we need to really start to bear down on, because smoking remains so very high in certain parts of the country that are often deprived. So those who can least afford in more ways than one are often those that are targeted. It causes a disproportionate burden on the most disadvantaged families and communities. And there's an estimated 20 billion still spent per annum on tobacco products. And sadly, and Bob will, and many of you will know, I have a particular passion for reducing smoking in pregnant mums. Because I just feel we get more bang for our buck, as it were. You get mum, but you very often get the person who's supporting her through pregnancy. So whether that's a partner or whether it's her mother or whatever, and then you give the baby a better start in life. And actually, we don't do well enough, and we are not seeing fast enough reductions there. And funnily enough, it's something that I spoke to the CMO about only this week, because as well as that, we also are seeing that smoking remains high in some ethnic groups, and particularly high in those with mental health conditions. And tackling smoking needs to be central to levelling up. And we also need to make sure that the commitments in the long-term plan are being delivered. The APPG report details clear recommendations for the up-and-coming tobacco control plan, and I will take them away, as you would expect, and reflect on them. But in the immediate, I'd just make these comments. Firstly, we don't want to lose progress over why we've made that progress over the last 10 to 20 years. Reductions in smoking prevalence are a result of continued support through the Stop Smoking services across England and that strong regulatory framework. It's therefore vital that we continue to support interventions that can make the most difference in helping people quit. We must continue to have a regulatory framework that stops people smoking in the first place and promotes smoking cessation, and encourages smokers to move to less harmful products. Second, as is indicated in the report's recommendations, we need to refocus our efforts on those areas where it's stubbornly high. So we need to be targeted, in my view, to start really addressing the variation across the country. For example, those pregnant mums, those smokers with mental health conditions, and we have a high prevalence of smokers in routine and manual occupations as well. We have to have a laser focus on any community where rates aren't falling fast enough. And if anything has brought it into sharp focus, it has to be the fact that we have just had 18 months of a pandemic that again affects the respiratory system. So for far too long, the harm from smoking has hit hardest in those areas that are already facing enormous challenges and have the least in their armoury to defend themselves against quitting and so on. So we need to work harder to support the change and support individuals. We're exploring many of the ideas that have been listed in the recommendations in the report. As you know, for example, we know social marketing is incredibly effective in supporting smokers to quit. We want to utilise the 10-year anniversary of Stoptober this year to deliver a high impact campaign, and we want to aim to reach more smokers than ever before and build on that success that we've seen to date. So finally, I want to continue working in partnership. The fight against tobacco is one that we can't win alone. It's really pleasing to see certain councils beginning to make more strides within their own areas, because obviously this also has an effect on air pollution, and I work across other departments on that within this space as well. We have to build on those long-term plan commitments, and we also have to get other government departments such as HMC to tackle illicit tobacco. You know, I regularly, when I chat to smokers, find that they've bought their cigarettes for £5. That is not from a shop. We know that it's out there. We need to work harder to make sure that we are cracking down on that, and the use of tobacco, because smoking a roll up without a filter and so on, we know is considerably more harmful as well. Also working with HMT on taxes and DEFRA on tobacco litter. The cigarette butts are still one of their primary causes of litter, but there's also the air quality issue. We will also be making the most of the new Office for Health Promotion and the opportunity this brings. And this will bring together DH officials and Public Health England experts to tackle this together in one united front. I just finally want to say that the UK will remain a world leader in the tobacco control plan, because I noted, I think it was recommendation 3, alluded to WHO, and we are proud to be a member of that WHO framework convention on tobacco control and remain fully committed to the convention. As I see in your recommendations, as I say, this was fully supported by you, and we must note that the impact that COVID has had on smoking rates and services, but focus our efforts on levelling up and take forward the momentum that's been built under the existing plan. Many of you have heard me speak previously about tobacco control and the fact that I am passionate about protecting people, because it is one of those harms that doesn't only harm the person who's smoking, it also harms the children in the house and other members of the house as well. It's clear with further investment and increased effort, the whole country would reap the rewards of how we reach a smoke-free 2030. And I am committed to being able to give us some interim targets so we can measure progress along the way, because I think that is another thing that came out of the recommendation, because we only have, what, 9 years, 8.5 years to get to that point. Now is the time to hit back at tobacco once and for all, and to ensure we have a future where nobody has to face the devastating consequences of smoking, whether it's by the individual or passively for those in the household or the workspace. I thank you once again, and I look forward to hearing from other speakers, but I'm really sorry, I've had a meeting shifted on me, so I cannot stay for very long. But we do have a debate tomorrow in Westminster Hall with Mary, so I'm sure whatever I don't answer now, people will bring up tomorrow as well. And on that note, that's it from me.
Well, thank you very much, Jo, for that keynote speech, and also declaring your passion for achieving a smoke-free Britain by 2030. Sorry, you're quite right. We do have the debate tomorrow. We understand completely that you've got to go for other meetings. We won't detain you, but you're very welcome, obviously, to stay as long as you can. What I can say to colleagues on this call is please post your questions and that you might like to ask Jo in the chat, because not only is Mary leading the debate tomorrow, but so am I. So I shall look forward to posing those awkward questions to Jo so she can answer them probably more fully in the debate in Westminster Hall tomorrow afternoon. So thank you for your contribution and for giving us your views, and indeed for staying as long as you can, but we understand completely if you need to leave. And indeed, I thank you for the welcome for the recommendations from the report. So we'll move on now to the clinical perspective on the All Party Parliamentary Group report from Dr. Ruth Sharrock, who is the respiratory consultant and clinical lead for treating tobacco dependency in the North East and North Cumbria ICS. I hope that she's going to give us her thoughts on the recommendations as a clinician. Over to you, Ruth.
Good morning. Thank you, everybody, and thank you, ministers, for your passion in that keynote speech. It's really inspiring. As I'm obviously a frontline clinician in our NHS, and it is absolutely evident to me and my colleagues in primary and secondary care that the volume of smoking-related diseases just creates such a huge burden, not just for the patients and their carers, but our health and social care systems that we're all struggling with at the minute. I spend my mornings here at the QE in Gateshead in the mornings looking after 2 respiratory wards, and the most common problems are all smoking related: exacerbations of COPD, emphysema, complications of cancer, respiratory failure attributed to smoking. And then myself and my colleagues have daily afternoon lung cancer clinics, again a direct contributor from the regional incidence of smoking. This picture's mirrored throughout the NHS. It's not just this hospital, it's everywhere up and down the country. This is people's bread and butter every day, and not just in respiratory, but those dealing with heart disease, strokes, other cancers, diabetes, mental health. We're just firefighting the long-term health complications of smoking related disease, and I'm not sure we're winning. And as you've referenced already, COVID has had a profound impact on the way patients have felt able to access healthcare services and caused a significant widening of health inequalities. And this has disproportionately affected our most disadvantaged communities, which correlates, as you've said, with those who already suffer the highest burden of smoking-related disease and the shortest life expectancies, particularly, as you've said, those with significant mental health problems. The North East has been particularly hard hit. It's what I'm spending my days trying to pick up the pieces from at the minute, but we've had the highest rates of smoking related mortality historically, and pre-COVID over 1/3 of our deaths directly attributable to smoking related disease. And as the Minister mentioned, in Gateshead and Sunderland, high prevalence is among mums in Gateshead and Sunderland. 1/4 of our mums at booking in at their first appointment are smokers, and we've had a 70% drop off in referrals and accessing stop smoking services through COVID. It's devastating. But I think probably, if you don't mind, the real stories are the most powerful. And give you an example, my office overlooks our labour ward entrance, and so if I smell a mum smoking, I scoot down the fire escape and go and see if we've offered her help. And a couple of weeks ago I met this amazing young girl. She was 22 and she'd been smoking for 10 years since she was 12. She's got a 5-year-old at home, and she lived with her nan because her mum had died in her 40s of a respiratory condition as a smoker, and she'd just had twins, and she showed me a picture of a beautiful boy and a girl. But anyway, I was saying, you know, have you had help? And she just declined it at the first offer sort of thing, felt she wouldn't be able to do it. But this is a young woman who's become addicted in childhood because smoking is endemic in our poorest communities, because of the accessibility of cigarettes to teenagers. She has already suffered huge personal loss, having lost her mum. She doesn't want to smoke. She certainly can't afford to smoke. And above all else, she was really clear. I said, you wouldn't want this for the kids, would you? And she's like, absolutely not. And that's what we know. Children of smokers are much more likely to smoke. We have to break the cycle. This will be their future if we can't help her more now. We need a much greater provision of support for those who are least able to advocate for themselves. If we're not pursuing every avenue to achieve a smoke-free 2030, I don't think we'd be able to look her twins in the eye. By then, they'll kind of be nearing the end of primary school, won't they? Starting to think about smoking themselves. Getting to the age where she lost her mum, and say that you wouldn't be able to look them in the eye and say we did everything possible to give them more time with their mum, extend her life expectancy, to improve the outcomes for our most vulnerable communities. We cannot level up unless we're tackling smoking aggressively. As a clinician, I can see you've already done, all of us can see that there's been a significant amount of progress already made towards the smoke-free agenda and the tobacco control plan, and the recent indication of support for better hospital-based tobacco dependency services via the long-term plan is hugely welcome. We feel like our Christmases have all come at once. It can't come soon enough, and it will target the most disadvantaged, because they're the people who are accessing out-of-hours emergency care, and from the poorest communities. It will have a very, very significant impact on the patient stories I see every day. So we're extremely grateful for the publication of the report and the work that's gone into it. Completely supportive of the comprehensive package of recommendations that have been made, and really appreciate you giving it such a visible platform for discussion and your time and energy on it. Thank you.
Okay, thank you very much, Ruth, for that clinical view of our recommendations. We're now going to move on to the very necessary policies that need to be implemented to deliver a smoke-free 2030 from Professor Linda Bauld, who is the director of the Spectrum Research Consortium, which helped to develop the recommendations in this report. So over to you, Linda, and I think you've got slides here. So
I do, and can you see my slides?
I can.
Lovely. Okay, thank you very much, Chair. I'm really delighted to be here, and thank you also to the Minister for her very supportive and inspiring words there. So I'm just going to take you through some of the main recommendations, and importantly, I'm going to highlight the evidence that we have, the strong evidence, stronger, I would argue, than most aspects of what we try and do in public health. Just a word on Spectrum. We're a large consortium of 10 universities, but also partners, including Public Health England, Public Health Scotland, and Public Health Wales, and the Smokefree Action Coalition. So unlike previous consortia, it's not just the researchers. We're very much working together with our important partners, and we provided evidence for the report, and also we're feeding into recommendations for the forthcoming tobacco control plan. So I just want to briefly outline the progress we've made to date in reducing smoking prevalence in adult children and smoking in pregnancy, and then take you through the recommendations. So you can see that we have made significant progress. Overall, tobacco control is a success story in England and across the UK. It's important to emphasise that, but as we've already heard, we have so much more to do. And you can see these consistent declines in the overall adult population in relation to prevalence, and these are very, very welcome. However, we do have, as we've already heard, these persistent inequalities, and these absolutely need to be addressed in the new plan. This is a challenge for many countries, not just the UK. But as you can see, and indeed, as the Minister was saying earlier, we have almost 1 in 4 smokers in routine and manual groups. compared to under 10% in managerial and professional occupations. And we know from studies that my team has done and others, we can reduce these inequalities through targeted and effective interventions, which is what we must do in the next tobacco control plan. And I continue to co-chair the Smoking and Pregnancy Challenge Group, and thank you to the Minister for her support for this agenda. As she rightly pointed out, we have made progress, but unfortunately it is too slow. And you can see on this slide here that the target of 6% of smoking prevalence at booking by 2022 we're not on target to meet that at the moment. So we need to do much more to support pregnant mums and families. Policy interventions have been a huge success. What we've done in the UK and in England is to change the environment around smoking. We've dealt with price, the product, promotion, and also place, the availability. And you can see that the declines in smoking prevalence have been due to the fact that the environment has been shifted, attitudes have been shifted, and effective policy levers have been used. And we need to continue this downward trajectory. And I hope that we can add later on more interventions in line with the recommendations of this report to show the relationship between declines in smoking and policy. So the recommended policy interventions, there are 12 recommendations in the report, are very clear. I don't have time to go through all of them, but I am just going to highlight a few of them, and all the evidence is set out in the report. And these recommendations are synergistic, they work together. So Henry's going to give you more evidence in a moment around how this can be paid for, the Smokefree 2030 fund. We importantly need to set targets. These have worked in the past to know where we're going in the interim and also the longer term. We need targeted investment to level up and reduce inequalities, and we also need low-cost policy interventions which are achievable to denormalise smoking. Now, in relation to the inequalities agenda, like most or many people in public health, I've been working primarily on the COVID-19 response over the last 14 months, and I think as we look towards the recovery, this focus on inequalities and improving the underlying health of our population to make us more resilient for future epidemics or pandemics needs to be a focus. So in the report, we talk about behaviour change campaigns that are targeted, advice and support to stop, which is strongly evidence-based, including in the NHS, additional support for those living in social housing and with mental health conditions who have high rates of smoking. And then for pregnant smokers, I'll just mention financial incentives, which are a strong evidence base behind them. And then the importance of regional programs. And of course, we have colleagues here from a number of regions who've achieved great gains in the Northeast and other parts of the country through regional offices and programs to reduce smoking. So behaviour change campaigns, these have been off the agenda a bit in recent years, and we have research from University of Nottingham and colleagues within Spectrum in the past that just shows you that the investment put, and that's the figure on this slide, into mass media campaigns can be mapped against people seeking support to quit, contacting the helpline, accessing online resources. So we know that these campaigns work, and in fact, in robust systematic reviews that we've done, we know also that they're highly cost effective. So we must reinvest in mass media campaigns to trigger those all important quit attempts, shine a light on the importance of protecting others from secondhand smoke, and the other interventions in the report. In pregnancy, there's much we can do, and Greater Manchester provides a fantastic example of a part of the country that is investing heavily in smoking cessation support for pregnant smokers. But trials that I and my team have done also suggest strongly that this may be an area where there is a case for targeted financial incentives, modest incentive added to NHS stop smoking services to really enhance women's ability to quit. Significant impact on quit rates, those who are provided with incentives, and also a highly cost-effective intervention. Final point I would make on this, despite what some sometimes describe as a controversial intervention, the public opinion studies that I and my team have done also suggest that the public will support financial incentives for pregnant women. Now, low-cost policy interventions, just a couple more slides. We need to close existing loopholes for regulations by enhancing quit messaging on individual cigarettes and packs, and I'll mention this. We need to regulate e-cigarettes and other nicotine products to protect young people, while still importantly providing these products to adult smokers to support them to quit. And of course, consider raising the age of sale, which has already been mentioned. Now, in relation to some of these interventions, we highlight here health warning on cigarette sticks and rolling papers, and work that's been done at the University of Stirling suggests this would be effective. Pack inserts promoting quitting, and also closing loopholes in a flavour ban. And I was really delighted, I just learned over the last couple of days that Lord Young of Cookham, who's one of the APPG members, and I see you're present, Lord Young, has a private member's bill on dissuasive cigarettes being introduced on the 14th of June. So I very much look forward to hearing how that goes. Consult on raising the age of sale to 21. There's strong evidence that this would have significant impact. As we've already heard, there's strong public support. Almost all smokers begin before the age of 21. We believe that raising the age of sale would reduce smoking rates in 18 to 20-year-olds by 30%, around that amount. And that then scales up to the number of fewer smokers we would have in that age group. And it really is important that we target that group. We know that smoking rates are highest at the moment amongst younger adults. So this is something we can do, it's acceptable, and if implemented, I'm sure we could assess the impact. So in 2025, we need to look forward and update the plan in light of progress, set out interim targets for that date, recommend improvements in data collection and analysis to inform progress, and also the report recommends reviewing progress to take further action if we're not on track by 2025. So I just wanted to emphasise that we believe that the policy recommendations in the APPG report that we recommend should be included in the forthcoming tobacco control plan are supported by strong evidence, not just from the UK, but from international best practice. They'll work together synergistically to increase the decline in smoking prevalence significantly. And even more importantly, they will help reduce smoking-related inequalities across the country. So thank you very much for listening.
Well, thank you, Linda, for that overview and support for the recommendations. Just a quick reminder, if you've been inspired to ask any questions, please put them in the chat function, and we will endeavour to see if we can come to you in due course at the end of after all of our speakers have spoken. We're now going to talk about how to fund the tobacco control plan. Very important for government to know how to actually fund any programme that is conducted. And Dr. Henry Featherstone, who is a policy advisor, will explain how the tobacco control plan could, and most importantly, should be funded. Over to you, Henry.
Thank you, Chair. Thank you for inviting me. I'm hoping everyone can see my slides. I want to point out I'm appearing here in a personal capacity. I do have a full-time job working for a pharmaceutical company, the significance of which will become clear as we go through the presentation. So my challenge is to work out how we fund this. So let me move on. So 4 seemingly unrelated facts I want to share with the group. So without getting turbo boosters behind the government's ambition for a Smokefree 2030, we're going to see significant disparities, especially amongst the disadvantaged, as we saw from Linda's presentation. And we're also seeing high levels of tobacco poverty. So tax is not the single big lever that we thought it was. So secondly, before COVID, the government promised that a US-style polluter pays principle approaching to funding tobacco control was potentially a way forward. Number 3, there's not a lot of money left for public spending. So currently borrowing 303 billion in 2021 to take us through the pandemic. And fourthly, and perhaps most significantly, this is the work of the academics at Bath University, Rob Branson and Professor Linda Gilmore. There's a tobacco company oligopoly, so 4 major tobacco companies operating in the UK, 90% of market share, with estimated profits of about £900 million per year. That's on sales of around 2 billion, ex-factory sales, not total sales. So as we've been hearing, tobacco margins between 50 and 70%. And what the central challenge is, and what we're seeing happen, is that tobacco companies are hiding significant price increases at the same time as excise duty increases. So it impacts their profits hugely, but doesn't necessarily have that much impact on smoking rates. So what could we do? Plenty of things. So it's not a perfect analogy, and this is what I'm saying. So the pharmaceutical market for branded medicine.
Henry, you've muted yourself somehow.
Oh, try that again. How's that? Apologies. Pharmaceutical company profits. Pharmaceutical companies have this extension of patent protection, which effectively gives them a short-term monopoly. But in the UK, we've been regulating this from a profit cap and price control scheme for the last 50 years or so. And typical repayments from this scheme to the Department of Health are about 500 to 600 million pounds per year. And as I say, the Department of Health has got extensive experience gained over the last 50 years or so in monitoring pharmaceutical company profits, closing any loopholes, and through the evolution of the pharmaceutical scheme that is monitored and renegotiated every 3 to 5 years. And importantly, what the scheme allows is it allows the department to encourage certain behaviours. So innovation, so new medicines, new vaccines, and research and development are areas that are given certain offsets to encourage that type of behaviour. And third point, Brexit. You didn't think you'd be talking about Brexit in an APPG on tobacco control, but there is a silver lining. So now that the UK has left the European Union, the UK government has a freedom to entirely set tobacco prices. Currently, they set about 88 to 90% of tobacco prices through excise duty and VAT. So what's the grand plan? So I'm hoping that that will move on. But So it's a profit cap and price control scheme for tobacco, heavily based on the one that's currently used in the pharmaceutical industry. And it would have three very clear objectives. So firstly, we want to control the market power and limit the profits of tobacco companies operating in the UK. How do we do that? Well, the way it works for pharmaceutical companies is they have to submit a very detailed annual financial return. Department of Health currently looks about 30 or 40 of these every year, so we're only proposing it would look at another 4 every year. We're suggesting that there be a profit cap of around 10% for tobacco companies. Currently, with the pharma scheme, 17 to 21% for pharmaceutical companies, 15% we're hearing for tech giants might be a global level. And the way it's implemented is a simple sales-based levy. You calculate the level of profitability allowed for an individual company, and each individual company has a sales-based levy on its sales of cigarettes. One key thing for this scheme to work seamlessly is we would need to level up the current disparity between taxation between hand-rolled tobacco and cigarettes. So we do it on a per stick basis. Okay. Point number 2, we want to shift tobacco company behaviour. Okay, we want to change their behaviour from focusing on tobacco to e-cigarettes and vaping products. Okay. You may want to consider that you don't over-incentivize tobacco companies and distort the market, but what you want to do is change their behaviour. Very important. And thirdly, quite explicitly, we want to raise funds to fund the smoke-free ambition. Okay, on the current level of profitability, and allowing a 10% profits, this proposal could raise in the region of £700 million per year. Okay. That's about 300 million of that we're suggesting goes straight to the Smokefree 2030 fund, leaving a 300–400 million surplus for other public health initiatives. Sorry, I'm having problems clicking through on my presentation. There we go. Right. So what should happen next? So we've got the forthcoming NHS bill. The suggestion is you would just need 10 paragraphs of primary legislation to give the Secretary of State the same profit control and price capping powers over the tobacco industry as you get with pharmaceutical industry. And as we've seen before, there is high levels of public support for this producer pays approach. What you would then be able to do is implement secondary legislation, okay, designed and refined with the great experience and expertise already residing in the Department of Health, okay. Important things you would learn from the pharmaceutical scheme is the information gathering powers of all elements of the supply chain, and publication of this data in an aggregate form, so parliamentary committees might be able to review and scrutinise this level of data. And who should oversee this fund? Well, certainly we've heard mentioned from the Minister the new Office of Health Promotion inside the department was going to be a key organisation. We're suggesting that it should oversee the administration of this 2030 fund. One of the things to flag, and the final point is, given the fact that you're trying to fund something from something you're trying to stop, you might want to consider how the scheme ends, and you might want to consider some of that surplus in the early years to fund things in the later years. So that's the proposal: profit cap and price control on the tobacco industry. Back to you, Chair.
Thank you very much, Henry, and I'm glad you managed to conquer the technology in the end. But I think food for thought there, because obviously for any programme like this, we have to demonstrate to the Treasury how it can be funded rather than relying on further either borrowing or further investment from the Treasury. Our final speaker this morning is, I think it's fair to say, we can all talk about the theories, we can all talk about what needs to be done, we can all talk about the recommendations, but actually the experiences of people that have been smokers and have successfully quit are all important. So our final speaker is Sue Mountain, who's an ex-smoker and survivor of smoking related cancer. So she'll give us her thoughts on the Smokefree 2030 ambition and why it matters to her and her family. Over to you, Sue.
Hi, as he said, my name's Sue Mountain. I'm one of the 2/3 of young children that got trapped into smoking at the age of 11. I got hooked, of course I did, because that's what the tobacco companies want with young children. They legally sell a product that they know is addictive and they promote it as cool. My idol in Greece was Olivia Newton-John, not the shy, boring Sandy that coughed when she had a cigarette, but the Sandy that was approved by the gang by being lured into smoking to look cool, sexy, the Sandy that stands on a cigarette to be sexy to get a man. I wanted to be that Sandy. I definitely didn't want to be the boring Sandy. Also, Audrey Hepburn, that little classy lady with a long cigarette. I was brought up with product placement. I believe that if I wouldn't have started smoking, if product placement wasn't used to promote it as sexy and cool. And if I'd known more about cancer that was related to smoking, and I didn't, I didn't know a lot. Tried packing in so many times. I regretted ever starting to smoke, but it is an addiction, which is so difficult to stop without help. This addiction is no different to drugs like heroin, but with this addiction, we know the pushers. It's the tobacco companies. I continued to smoke until I got cancer of the larynx. Believe it or not, I got told I had cancer, walked out that hospital. Guess what? The first thing I went for? A cigarette. I needed it. Of course I needed it. I was addicted. I needed it to help us. I'm lucky, I'm now free of cancer, but I still get checked every 3 months. Can you imagine what it feels like to go through these checks? The camera up my nose, down my throat, and obviously the thought, has it come back this time? The worry of cancer will always be in my life, thanks to smoking. Totally agree with the report about smoking and depression. I too was very depressed when I smoked. Believe it or not, I actually felt guilty smoking, but I couldn't find a way to stop. My guilt led to depression, and when I became a single parent, you would think I would pack and smoking. No, still managed to find that money for cigarettes as a single parent of 3 children. I needed them. I was addicted. Even though my finances were very tight, I managed to buy them. And guess what? Brought on more guilt and more depression. Since quitting, I haven't felt depressed or anxious. And guess what? I've got lots more money. Hopefully, the public's health is at the heart of the government's priorities. There's still 6 million smokers, that's 1 in 7 adults. We've got to motivate more smokers to make a quit attempt. And we have to reduce the number of children and young adults who start smoking each year. This won't be cheap. Public spending on tobacco is estimated at 14 billion a year. Tax revenues don't cover the cost of smoking to society. Survey carried out by Ash in March 21 found 77% of people supported making tobacco manufacturers pay a levy and a licence fee to the government to help smokers quit and prevent young people from taking up smoking. God, do I agree with this? Make the pushers pay. Get tobacco companies to pay towards a smoke-free 2030. I honestly so promote this smoke-free 2030. I don't want my grandkids growing up in a smoking society. My youngest is 3. I'm hoping she never comes across people that smoke when she's a teenager, and therefore hopefully she'll never be lured into smoking. Fully support the APPG report, urge the government to accept its recommendations. We've got a real opportunity to end them, end the harm that's caused by tobacco for once and for all in England. And we can become #1 in the world with a bold, ambitious tobacco control plan. I really hope we are the first country to see the end of smoking. I have a duty and responsibility to do so as soon as we can. Come on, let's be smoke-free by 2030. Thanks to everybody that's put in a lot of work to this report. I totally endorse it. Thank you.
Well, thank you very much, Susan, and for bravely sharing your experiences and your hopes for the future, because I think, you know, this is what we're all about, actually achieving exactly what you wish for, and actually hearing from someone who is an ex-smoker and has managed to quit, and the reasons why you think it's so important, I think are absolutely vital to all of us. Now, the good news is where we come to the question and answer session for anyone that has a particular question. We don't have very long. Can I ask if any of the members of the APPG have got any questions for any of our speakers, or want to make any comments before I take any other questions that we've got? I'm looking around the screen desperately to see if there's anyone. If you could raise your virtual hand, that would help me, because I can then see more of the people involved. George, can I just ask you, you've got your private members bill on, I think it's being published on Monday. Can you just tell us what the position is with that before we take any other questions?
Well, thank you. Can I thank all those who have given such fascinating presentations, really informative and an excellent APPG presentation. As a former Chief Whip, I know the hurdle that any private member's bill has to cross before it reaches the statute book, and it's a bit of a long shot, but basically when I had Joe Churchill's bill job and was negotiating with the tobacco companies, I suggested we should have a health warning on every cigarette. and they said I couldn't do this because the ink was carcinogenic, and and it's been one of my objectives ever since, is to try and make some progress. As you said, it's one of the recommendations of the APPG report, and so I put it forward. It's cost-free. It's in line, I hope, with government policy. It's not right at the top of the private members' bills, so it's behind several others. So if I was a betting man, I'd say this is probably a 10-to-1 shot. It's got to clear all stages in the Lords and then all stages in the Commons. I don't know to what extent the anti-tobacco lobby is still powerful in the Commons. When I first started, it was very powerful indeed. You have the Libertarians who don't like any government control of anything. So I don't know where Chris Chope, Philip Davis are on this. So that's a bit about my bill, and obviously I'd welcome any support from Lords, fellow peers, when I get my second reading. I did put a question in the chat, which Henry has had a shot at answering, which, having been a Treasury Minister, I'm slightly worried that you raise all this 800 million from the polluter pays. It does indeed go through to the Department of Health and the Office for Health Promotion, but the Treasury simply dock it off the budgets. And so you're back where you started. And Henry has suggested a memorandum of understanding, which the Treasury would have to agree to, or one would have to somehow put it in the legislation to make sure that it was ring-fenced. Those would be two ways forward. Enough from me.
Thank you. Right, have we got any other questions? We're running out of time now. I think we're almost at the witching hour, as it were, in terms of ending our session. So can I say we'll take any questions that are raised, have been formulated in the chat room. As I've said, we will endeavour to raise these tomorrow with Joe Churchill, as well as obviously the report in the Westminster Hall debate. So can I, on behalf of everyone, thank all of our speakers and all of you for attending. I think the key point here is that obviously we are setting out a bold set of recommendations to deliver a smoke-free UK in 2030, and indeed making sure that we not only deliver that, but we level up our communities and build back fairer after COVID. I'm particularly, my particular passion here is certainly to encourage pregnant women to give up smoking for the good of their baby, and also to get their partner to give up smoking as well, to enable them to indeed enjoy the family, and making sure that people aren't encouraged to smoke. I think the other thing that I think is very important here, and we heard the statistics about young people smoking, and the reality is that if you start smoking in your youth, you are very likely to carry on into adulthood, and then afterwards, of course, suffer the health consequences of so doing. So the more we can do on reducing the prevalence of smoking amongst young people, the better, because that will literally cut off the supply of smokers for the big tobacco industry. So I suspect that we are going to face a battle over increasing the age of sale, but we've embarked on many battles as an all-party parliamentary group and won them. And I think this is one where we can quite clearly do together jointly. So we will obviously be supporting the government in its delivery of the ambition of a smoke-free Britain, and we'll make this a continued priority for the APPG. And you never know, we may be able to close the APPG down because we've achieved a smoke-free Britain. But that's a bit of a far off. I mean, George has got a 10-to-1 shot. Well, I suspect that in 9 years' time, we might be able to achieve closure of the APPG, but I don't think we're there yet. And I think the other important factor, which has come out very importantly during this session, is that unless there's further bold action by the government, Smoke-Free UK 2030 will not be achieved by 2030, and it will carry on, and there'll be diminishing returns. So can I thank all of you for attending, thank all of our speakers, thank Ash and all of those involved in developing the report, because I think it's very, very much appreciated. I'd also like to thank Mary Foy in particular, who's been a relatively new MP, but has taken on this task quite considerably and has done a lot of the media this morning, and congratulations to you. I look forward to the two of us and others joining the Westminster Hall debate tomorrow, and indeed putting the concerns to the Minister and promoting not only this report but our long-term ambition. And with that, I'll draw the meeting to a close. Thank you all for your attendance, and let us hope that we can look forward to the recommendations we've made being endorsed by the government and being implemented. Thank you very much for attending.